Well, good evening. For those of you who may not know me, my name is Trevor Hancock, and I'm a professor in the School of Public Health and Social Policy at UVic. And I've been organising this series of 3 presentations on the theme of healthy cities. And some of you may have been here 3 weeks ago now when Jason Corburn from UC Berkeley was talking. So this evening is the 3rd of that series, and I want to just start by thanking the Committee for Global Studies at UVic and SHIRK, who are the organisers and funders of this, and also for the Centre for Global Studies, which has helped co-sponsor Sharon's presence here. As you can see from up here, Sharon has come from Australia, from Canberra. As you will hear shortly, that's not where she started in life. And she has a position there which is not on this slide, but I think is one of the neater titles in public health. She's a professor of health equity. And she comes by that title honestly. So she has been in Australia since 2005. Although I don't think she spent much time there in the first 3 years, because she has a background in health promotion and epidemiology, and worked in Ireland for a number of years. And then in 2005, at the same time as she moved to Australia, she became the director of the Scientific Secretariat for the World Health Organization's Commission on the Social Determinants of Health, which was led by Sir Michael Marmot, and had a very distinguished group of people on the commission, one of whom, for example, the Canadian representative was Monique Béjean, the former Minister of Health, and a real champion of health and public health and population health. And the commission, in fact, had a lot of support from Canada. So Clyde Hertzman, and I don't know if any of you knew Clyde Hertzman, who died about a month ago now, very suddenly, but he, through help at UBC, the Human Early Learning Partnership, led the Early Child Development Knowledge Network for the Commission, and Ron Labonte at the University of Ottawa led the Globalization and Health Knowledge Network, and I served on the Knowledge Network on Urban Settlements, which is how I met Sharon. So she was very tightly involved between 2005 and 2008 when the Commission reported with developing this very important report on the social determinants of health at a global level. And following that, she got some funding from the Rockefeller Foundation to establish something called the Global Research Network on Urban Health Equity, and she and I worked together on that between 2009 to 2011 roughly, developing for the Rockefeller Foundation primarily a research agenda on urban health equity, meaning how do you reduce inequalities in health, particularly in the cities of the lower and middle income countries. So that is the sort of work that Sharon does. She now is working with a whole team of folks at the Australian National University in Canberra, and her areas of interest span social justice and the determinants of health, climate change and other ecological changes and their impacts on health, and cities. And so it's this combination of social justice and social equity, climate change and ecological change, and cities that are going to be sort of the nexus of this in the context of global changes and global determinants. So without any further ado, I'll turn it over to Sharon, who's going to have to be a little contorted because we had a bit of a computer challenge, so she can't see what's on the screen without doing this. So if you see it, it's not a tick when she does it.
Trevor, I was going to say, can we turn those lights off? Good.
I did that without having to do anything. Thank you. So thank you very much for the invitation to come and speak. It's delightful to be in this freezing cold weather. When I stepped on the plane in Australia, it was 30 degrees Celsius, but now I feel very much at home because I'm from Glasgow in Scotland, so this is the sort of weather that we should be experiencing at this time of year. Well, all through summer, yes, indeed. So yes, so thank you for the invitation to talk. I'm going to say a little bit more about Trevor when I get to the end of the talk. So yes, what about urban health equity, and what does that mean at the global level? So yes, I am going to do some of this, apologies. There are major inequalities in health outcomes globally, between countries and particularly within countries at the city level. Often when we started doing the work globally and thinking about urban health, people said, but isn't the big problem in the rural areas? Well, of course there are major health issues in rural areas, but when you start to look into the data, some of the within urban inequalities are in fact greater than what you might experience at the rural level. So it's very important that we do put a lens on the urban stage. And because I am from Glasgow in Scotland, I thought I would share some of these data that we used in that WHO work that Trevor referred to. And the fact, so coming from the east end of Glasgow, which is where the socially disadvantaged area that's mentioned in the top of the slide, so men in particular, men, it's often always you that are more likely to die younger around the world. But so for men living in the more socially disadvantaged parts of Glasgow, there's a life expectancy. There are places where there's life expectancy of 51, that says 54, but of 51, compared to the more affluent areas over in the West End. And colleague who's over at the University of Glasgow in the West End, which is where this affluent area is positioned, men can expect to live up to about 82. And you can see just the contrast within a city compared to some averages with countries around the world. Why on earth in a rich country like Scotland, it's not the richest in the world, but it's a rich country, why we've got such inequities in something like life expectancy. We've got a major, in terms of non-communicable diseases around the world, it's an escalating problem, particularly in low and middle income countries. That's where the burden of non-communicable disease really exists now. And just to give you some figures, I'm going to get the data, the numbers out of the way, and then we'll move into things perhaps a bit more interesting. But just to show you how that's distributed, so diabetes, a major chronic disease problem, and how that's in China, the data is quite old, it's much worse now. You can see how that's distributed, and often these non-communicable diseases are diseases of the city. And then there are, of course, still some of the incredible infectious disease, maternal child health deaths occurring, particularly in low-income countries, but it still remains in some of the middle-income countries. And these are some data from Africa, from Kenya, and I don't actually have the pointer, but here. So I think Jason Coburn, who spoke before, I think Jason was speaking about some work that he's been doing in Kenya, but this example is the Kibera slum, one of the biggest in the city of Nairobi, and you can see just how we've got Kibera and Embakasi, these incredibly high levels of what we're looking at, under 5 mortality, so early child death. That's the end of the data per se around the epidemiology of the disease distribution, and really it's just illustrative of the extent of inequities between countries, between cities, within cities. So what on earth might we do about it? And why would we be concerned globally? What are some of the issues, or some of the urbanisation issues still to occur? For us in the rich world, we've urbanised. We are still sprawling all over the place, but we've pretty much done our urbanisation. and there's a lot that we can do about it and do it better. But for where most of the urban growth is going to happen is in low and middle income countries. So there's an opportunity to think about urbanisation in a way that's good. If we don't, then of course it's got quite profound implications. And a lot of the urbanisation that's about to happen will happen here in countries in Africa, and you can see quite a lot of the spread will also take place across Asia. So why would we care? Why are we even in the room thinking about these issues? The work that Trevor referred to that I was involved with, that we were both involved with, the Commission on Social Determinants of Health, which is this report on the right-hand side of the screen. So the Commission took a social justice perspective on this. They said it's a matter of social justice. We use this strapline, it's killing people on a social injustice, it's killing people on a grand scale. It's an ethical issue. Some people buy that, some people don't. And if you don't believe it from a social justice perspective, there is also an efficiency, an economic efficiency argument for why we should be doing something about these more broad inequities, but city inequities. And these are just some data from Australia where we commissioned some work to see what would the saving be if the Australian government took health inequities seriously and tried to do something about it. And you can see this is Australian dollar savings, not an insignificant amount of money to be saved. So if you're interested from a social justice perspective, of course there's clear reason to do something. If you're interested from an economic perspective, there's also an argument as to why we might want to do something about this. But Amartya Sen, who was one of our commissioners, so Nobel Prize economist, he speaks about having the freedom to lead a life that we have reason to value. Why on earth are we here on this earth? Having a life that we have reason to value. And so he speaks about, so the economy, the money aspect side of things is important, but it's not the only thing. Having control over our life is a very important part of having the freedom to lead a life we have reason to value. And when we put all of that together, so if we're saying we want to do something about these health inequities, we think it's important, either from a social justice or from an economic perspective. And we think it's something to do with, within that context of freedoms, something to do with material resource, something to do with control over our lives. Then when we start to think about urbanisation and ways of urbanisation and what that means for health, then we can start to incorporate these things down the left-hand side, but it means we have to start to put people, perhaps for us in the room, that, of course that's what we do, we're concerned about people, but certainly a lot of the urbanisation, the work that we've been involved with globally, urbanisation is not about people, it's about the economic heart, the economic driver. So thinking about these things down the left-hand side, one might argue are very important in terms of freedoms, material resource, building psychosocial control, political voice, which I'll come to shortly. And all of that, I would argue, is what development, human urban development is all about. And one of the ways that we might consider urban development being done around concern for people, for society, we might measure the success using the distribution of health. If we saw those urban health inequities reducing, then we're doing something right. Then we've got human, people-focused urban development. So we could use the distribution of health as a marker of successful urbanisation. So, do we have the concrete road to freedom, as I've tried to pretend that we're talking about that long walk to freedom, but using urbanisation as a way of thinking about helping people to have material resource, having psychosocial control, and having political voice, that are the elements of having freedom to lead a life that we have reason to value, which are vitally important for health. If you want, I think the Canadian Public Health Association has done this lovely, easy way of understanding the social social factors that affect people's health, not specific to cities, but you'll see how it plays out that it does relate to cities. So often from a health perspective, people say, okay, well, you've got to do something, it's about health care, it's in health services, and we would certainly argue it's much more than that. So asking the question, now this I can't see, and I don't know all of the words on it, I'm just going to step down. Why is he in the hospital? Why does he have the infection that he's got in his leg? You can just imagine a child saying this, which is what this is supposed to be. Why has he got a cut in his leg? Well, it's about that sort of broader physical environment that he's playing in. Why is he playing in such an area that's not really very good, or that it puts him at risk of getting the cut in his leg? Why does he have to live in such a neighbourhood? You can read why that is. And why can't he, because he's living in such a neighbourhood, because of the lack of material resource to live elsewhere, why is that the case? If the father's unemployed, why is that so and so on? So I just think the Canadian Public Health Agency has done a lovely job of capturing the social determinants of health in a way that I think is very easily explainable. So that's in essence what I'm going to speak about in terms of urban health inequities. And if you want to read some of the work that Trevor referred to, this GNU, the Global Research Network for Urban Health Equity, this was the report that we did, is still available online if you Google GNU. And if we were really lucky, Trevor would sing the song at the end. We developed a song to go with it because it was such a rubbish acronym. We thought if we had a song, people might remember. So there's 4 areas that I want to talk about that we captured, both in that global, the WHO's report, and also in GNU. The urban planning, social conditions, climate change, and governance. So in terms of the broad sort of urban design, urban planning, built environment aspects, you may be familiar with the image. So the favela in Brazil, the favela on the left-hand side, and the very affluent tower block with the swimming pool on the right, on each of the levels on the right-hand side. So not only is the physical environment here really quite detrimental for health, but seeing across the fence the relative inequity. There's been a lot of work done internationally that tells us that this relative inequity between this location and this location is very harmful, particularly for mental health. The ongoing chronic stress that's associated with that is detrimental to mental health. So this sort of planning of positioning of these two built environments is not good for physical and mental health. And I've got to do the obesity one. Trevor hates this, but is urban planning a healthy weight issue? So this is in the US, I believe. So how does a child who lives in the red house want to get to play with the child who lives in the green house? And there's no connecting pathway between these two houses. So there's 3 options. The first option is they don't go. The child stays in the house, plays on, I'll stereotype, it plays on the computer, and doesn't have the social interaction with the friend in the greenhouse, doesn't have the physical activity that's associated with being outside playing, and there's a huge literature on all of that. So that's one option. The second option is the child walks or gets on its bicycle, goes down around here, up and round and up to the greenhouse. The third option, which is what usually happens, is the child gets put in the car and gets driven down and around to play with the friend. So not very good from a health perspective. It's not very good. It's not the child isn't expending any energy. Does get to have the social interaction, which is very important and very good. And if you're interested in terms of greenhouse gas emissions and fossil fuel use, of course, there's an unnecessary route. But as Trevor, we were talking earlier today, there is, by and far, in terms of the obesity, non-communicable disease risks, physical activity is important, but the food and the nutrition of food is probably more important in terms of healthy weight. And what you're looking at on the screen, being Scottish, being from Glasgow, this is our favourite food, it's the deep fried Mars bar. So the chocolate bar is this thing in the middle, and what we do is we put it into a batter and deep fry it. It's not the worst. I was saying that I have seen deep fried butter on a stick in the US. I think that probably trumps the deep fried Mars bar, and it actually tastes quite nice. But what we have from I suppose a planning, or certainly a retail planning issue, is this is very readily available. There's a paper in the British Medical Journal which said it was looking at, is this an urban myth? Can you get this really in Glasgow? And you most certainly can. The colleagues in Glasgow find this. So it's very readily available through many of the chip shops that are on every corner, particularly in low-income neighbourhoods. So it's out there, it's readily available, it's very affordable. So you go into the chip shop, you buy your deep fried pizza, and for your dessert you have your deep fried Mars bar. So it's out there, it's affordable, and it is now culturally acceptable. So I'm saying again how within Glasgow, within the eating, the quite refined eating establishments of the West End, this sort of thing, not looking like that of course, but this sort of thing gets served on a plate for dessert. It looks fantastic and it's got a little juice and all that, but it's a deep fried Mars bar. So the normalisation of this sort of food, partly through its greater availability and affordability, has shifted the norms. And Glasgow has one of the highest levels of common heart disease in the world. And then in terms of still keeping with that sort of built environment, that urban planning, urban design argument, in terms of equity and access to transport, because if we are trying to encourage active travel as an important public health message, which we most certainly are, then these are just some analysis, some qualitative work that we did in ACT, where I live in Australia. And I won't read through all of that, but from an equity, putting an equity lens onto why on earth is it that public transport is most certainly not used among low-income households and low-income neighbourhoods, and you can read why that might be. And then, so we talk about these walkable neighbourhoods. I put this slide up, it didn't have the text at the bottom, I put this slide up at a meeting, an international meeting, and said, I found these data in this report, and look how walkable some of these Indian cities are. For public health, fantastic. People are out there walking, these incredibly high percentages, saying within Kolkata, about 90% walkability within the city. And somebody very rightfully put their hand up from the audience and said, but you're absolutely mad, there is no public transport, there is nowhere to walk. People are having, there's no public transport, people don't have cars, they've got to walk from one side of the city to the other side to get to their employment, so of course they're walking. It was just the wrong question that was asked in the survey. So being very conscious of data, I actually use this more to say be very careful of how you interpret some data. You can read the sort of the figures there in terms of equity issues to do with walkability of cities. So what about social conditions? Some of the work by Richard Wilkinson and Kate Pickett, who have looked at income inequities and how these income inequities correlate with health and social problems. And suffice to say, without having to read everything up there, the greater the inequality, the social inequality, the worse the health and social issues within, that's at the country level, that's not city level. There are very few data that allow us to do that at the city level. I'm going to come back to some of the data issues. But so the more unequal a society, the greater the health and social problems. It's not rocket science, but there are these correlations that suggest that. And many places around the world have become more unequal. I see Canada's not the worst, but you have over time become more unequal as a society. The US, by far, one of the most unequal. You can see the colour coding. So the darker the colour, the more unequal these countries have become over this 30-year time period. There are relatively few countries that have actually become more equal. So this is to do with income equality. So given that we know the more unequal a society is, the greater the health and the greater the social and health problems, the fact that over time, these at the country level, we're seeing greater inequity taking place, then that poses serious concerns for health. At the city level, and these are some of the recent UN Habitat's State of the World Cities report that you may be familiar with. But so this is just for developing countries. We don't have it through UN Habitat for the developed countries. And these are the worst countries. So if a country, so a Gini coefficient, the closer to 1, the Gini coefficient, the more. If we had a Gini coefficient of 1, there would be absolute anarchy within society. It is just totally unequal. The closer to 0, the more equal the society. And 0.4 is considered the alert line. So once a country, or in this instance a city, goes above 0.4, then you start to see the demise of social fabric, as they describe it. And these are the most unequal cities based on the UN Habitat's database, and I'll let you read along. Most of them are in Africa or in Asia. In Africa or in Latin America. We, the countries of the developed world, tend not to have such high levels of inequality. There's a number of reasons for that, but we tend not to have such high levels. But having cities, which of course these cities have phenomenal large populations, having such inequity, knowing how that correlates with health and health inequities, that's very, very dangerous. I'm not at all suggesting that we want to encourage better working conditions to allow us to eat more Big Macs, but you might have seen The Economist's Big Mac Index. That's really just a way of working out the standard of a comparable measure of standard of living between countries and cities around the world. And what this is telling us is people in Nairobi have to work that length of time, that number of hours, to buy a Big Mac, compared to in Chicago, Toronto, you only have to work that length of time, and it's all adjusted for cost. So it's an indicative of the salary, the amount of money that people are earning through work. As I said, I'm not recommending that we want to be concerned about having access to Big Mac, but it's about having access to sufficient resource and the inequities that we see across the world. There are still some very basic things that we may take for granted in our countries. Access to sanitary conditions, toilets, clean running water. That's still very, very socially graded in many cities in low and middle income countries. These are just some data from India showing how things are, in terms of access to these, what we would consider basic health needs, how it's still very highly socially graded. Access to immunisation, postnatal care, having a sewage system. So in terms of social factors, social conditions, having these basic needs not being met, sitting on top of these other inequities in terms of social conditions is really quite challenging. And we do know the softer side, as some people describe it, social capital, social cohesion, social networks, vitally important, particularly for mental health, but also for physical health due to the relationship with chronic stress. We know that greater social capital is protective of health, and you can see this is in the States, how with increasing neighbourhood There are different ways of getting social capital or social cohesion, but at that neighbourhood level, with increasing civic participation, it's a form of social capital, how the inequities by race decrease at the neighbourhood level. So there's something to be said for not only do we need to think about the material resource aspect, but thinking about that psychosocial control, psychosocial engagement with our neighbours. And why does it matter? How does social inequity get into us at the biological level? How does this affect our health? And there's a whole number of issues that are, some of them I've touched on already, and some I won't talk about. Here's the living in neighbourhoods, high social disorder, lack of safety. One of the issues, of course, in that urban design discussion, you're going from the red house to the green house and there's no connecting pathway. That might be okay, having the connecting pathway is okay if you live in a safe neighbourhood, but certainly we know from the work globally that issues of safety are absolutely one of the reasons why people don't go out and move about. It's a complex way. But living in that sort of neighbourhood, along with all of these other social factors, social inequities, contributes to long-term chronic stress. I'm not going into the biology of all of that. That affects chronic disease and affects anxiety and depression. We know that there are much higher levels of anxiety and depression among people that experience this, partly to do with social exclusion processes, but there's a whole literature now on how that gets under the skin. Nancy Krieger down in Harvard does some lovely writing around this if you're really interested, the embodiment of social inequities. So then moving into the climate change space, how does climate change, urbanisation and health inequities intersect? And I'll just mention just a few things. So we've got heat stress, we've got this urban design, and I use that in terms of the emissions. We've also partly related to that is the transport, but that's also to do with the air pollutants. This is supposed to be to do with food security, but I don't know how I'm going to speak about food security. Thermal stress, heat stress is certainly one of the areas that is within the city environment. Heat stress is receiving, well maybe not in Victoria, but certainly in the country that I live in Australia, we really have experienced heat stress quite significantly. We've had in Canberra, where I live, just this summer, we had more than 10 consecutive days over 40 degrees Celsius, which is really quite unusual for us. We would expect that further north in Australia, but not down at the levels that we're at in Canberra. And whilst there are certainly deniers that it's to do with climate change, there is a sort of a general consensus that we have experienced climate change. We were in a 10-year drought in Australia. We've now come out of that, and we've got incredible flooding happening in the north of the country. Fires happening because of the dryness and the heat down in the south of the country. So heat stress is something that's on everybody's lips at the moment in Australia, but of course it's really affecting many of the populations in low and middle income countries, and partly because this is a horrible picture of people in New Delhi, the workers in New Delhi. So many of them manual, out in open working environments, so there is no shade available. And when you've got prolonged periods of time, or increasingly prolonged periods of time in that sort of heat, the other working in that sort of heat, the other part of the heat stress is in terms of its relationship with the built environment. So again, in many of the cities in low and middle income countries, but also in high income, the lower income households are the ones that are living in the households that have the corrugated roof, and of course just love the heat, keeps all of the heat, and when you've got more extreme temperatures and more of it, then those populations are being put at risk. But we do know that there's one of the ways to overcome heat stress is to provide green space. So being able to have shade, being able to have places within cities that help ameliorate that sort of urban heat island effect as well. So places with green space are very important, helping to cool down the city. But access to green space is very socially graded. And these are some data that, so this is just all-cause mortality. And so what we're looking at, so along the bottom is exposure to green space. So on the left-hand side, this is the least exposed to green space, or least access to green space. And on the right-hand side, the most access to green space. So the first thing, of course, you can see is that those who have least access have higher levels of all-cause mortality, and it's exactly the same when you break that down for circulatory disease, which is often very impacted by heat. But then what you see is, so what we've got is income group 2, 3 and 4, so it's all relative to income group 1, and income group 1 is the highest income group. So really, income group 4, the lowest income group, has a much higher instance of all-cause mortality compared to the more affluent groups. So in every instance we have a social gradient, and we know that the green space so we can see how how the all-cause mortality differs across the axis. So one, we need to get access to green space, but we've also then got to think about how that's socially accessible. And you can think about the picture that I showed with the question of the concrete road to freedom. I should have said that picture, which is called Witness to Mortality, is in Glasgow. That's basically one of the slums of Glasgow. Now, access to green space in that part of Glasgow is negligible. We're not experiencing heat stress in Glasgow yet, but if we were, we've got all of that concrete, and there's nothing helping to cool it down. And of course, the other, in terms of climate change, one of the things that we're experiencing is sea level rise. And sea level rise, of course, if you live on the coastal areas, is a problem. And most of the cities are being built at the coastal areas. Now, if the coastal area is a low elevation zone, which is what this LECZ means, really all you need to take out of that visual is there are very large numbers of populations in this instance across Asia, but going really from sort of North Africa across Asia, there are very, very large numbers of populations being placed into cities that are being built at a level, a ground level, that will become flooded due to sea level rise. You're at risk of flooding due to sea level rise and from storm surges. Now that we have more and more extreme storm surges due to climate change. So if we've decided to build in these low elevation zones, who's living in the low elevation zones? Predominantly, not always, but predominantly, it's in the houses, it's the lower income populations that are being positioned there. It's the land that other people don't want to live on. A major equity issue. There's been incredible battles happening around some of the Indian cities that I'm aware of because of that. And then this idea of, well, how, if we're experiencing climate change and we've got these issues of heat stress in the built environment in cities, and we've got these concerns of where we buy our house and where we are located in cities related to climate change. This adaptation apartheid, which was coined by the United Nations Development Programme, which Kirk Smith has written about from a public health perspective, the idea of if we're rich or reasonably affluent, like ourselves in the room, we buy our way out of it, so we can adapt our home environment. You know, we can have the air conditioning, we can install air conditioning to keep cool. So we're not going to die from it. It might cost us a bit of money, but we're not going to die. But as of course the poor will most certainly die, and we're seeing that happening. The most vulnerable, from a health perspective, the most vulnerable to climate change through the city lens is the elderly population, children, and people who are already sick. Certainly with heat stress, that's where the populations that we're seeing it is. There are things that we can do. So of course we've got to deal with what we've currently got as far as climate change within the city environment and climate change is concerned. We have to adapt to it. But we want to mitigate further harm, further degradation. And there are ways of doing that, certainly through cities and through the transport policy. There was some modelling done that's been reported in the Lancet by James Woodcock and colleagues, who said, okay, well, if we want to reduce emissions, and I can't remember the number, if we want to reduce emissions to the UK target, greenhouse gas emissions down to their target, what needs to be done within using transport, what needs to be done? So they identified active travel, urban active travel, plus a shift to low emission vehicles. Again, not rocket science, but they calculated how much of that would need to happen. And this really, all to take out of these numbers is, if we said at the upper end, we said in the UK or in Delhi, so about 20% of ischemic heart disease, the year's life lost from ischemic heart disease would be saved. Now that's an incredible saving, that's a real health saving. So you shift through your transport policy as a mitigation approach, but you also get these very good health co-benefits as a whole. And then what about issues of governance and power? This absolutely underpins everything else. You know, you can think about transport policy, you can think about labour policy, etc., etc. But it's all of that is determined by governance and power, in essence, within there. And this is referred to as the cracking the health equity, the nutcracker, with health equity, with little nut in the middle that we're trying to, health inequities I should say, we're trying to crack. And we need the policy approach, and we need the bottom-up community action as well. And I'll give you the example of, from a policy perspective, an example of where policymakers were undermined. So I spent a long time in Ireland. It's a country that loves alcohol, and it loves to have fun, and it loves alcohol and all of that goes with it. We're renowned for alcohol consumption. So I would say that it was at the time of the Celtic Tiger. So Ireland was just booming, there was money galore. They were thinking about how to really regenerate Dublin, the capital. And in the centre there's an area called Temple Bar, and they wanted to really revitalise Temple Bar. And what, in essence, there was some really quite progressive urban planning on the books for what was going to take place in the city centre. So, good local government coming together, all the policy people really thinking about it quite seriously. The Irish government, you may then of course know that Ireland went completely belly up in recent years, and one of the reasons for that was because of the very close relationship that happened with the developers. And there were just these parallel processes that were happening where the private developers were doing what they were doing with no regulatory input at all. And what, much more complex than that, but in essence what happened was the centre of Dublin and the Temple Bar area became one of the most disgusting parts of the city, in terms of there were just people everywhere being sick due to the ready availability of alcohol 24 hours a day. It was bringing in people into the city centre for, in essence, just excessive alcohol consumption. So it's not a part of the city that people, Dubliners or many others, really want to spend any time in. There are many other ways of enjoying alcohol, but this was not the way that was good from a health perspective. It was just a disaster. From a public health, it was an absolute disaster, and particularly for young people, it created all sorts of safety issues as well. So I would say that was a complete disempowerment of local government urban planners. The planning policy didn't happen in the way that they wanted it to happen. And I'd love for people involved in that space, I'd certainly love to get your thoughts on it. But there are examples of things being done really well. I think in one of the networks, real participatory governance through the South American Network for Sustainable and Just Sustainable and Fair Cities. This is a before, this is a favela in Rio de Janeiro, and this is an after. Now, there's many ways of developing that, but the point of showing that development was it was community-led, with complete support from local government, with private investor input. So that a very nice participatory model to do that sort of development, and there hasn't been any formal evaluation, but certainly health promotion colleagues describe a real engagement, and particularly around the urban youth living in those neighbourhoods. It's now much safer to be out and about. So to try and wrap up everything that I've been saying, trying to pull all of that together, because that was a bit of a whirlwind of urban planning, urban design, social conditions, climate change, and something a little bit to do with governance. And of course they're all interconnected, and there are many other things that also come together to create this idea of a sustainable, a fair, equitable and healthy urban environment. So what might be important? Well, one thing is political will, and very high level political will. On the left hand side this is Monique Bejan. So this was a number of the commissioners that were part of the WHO's Commission on Social Determinants of Health. So the commissioners were these very high-level political appointees. And this man here is a former Surgeon General for the United States, David Satcher. David said to us, come to New Orleans, this was post-Hurricane Katrina, come to New Orleans and we'll use Hurricane Katrina to show the social fault lines that were really the issue for the rebuilding of New Orleans post-Hurricane Katrina. So we went to New Orleans, we met with various people in the city, and this is the mayor of New Orleans. So we had it was a 2-day meeting, and we spoke about all of the sort of issues that I've just spoken about. And he stood up at the end and said, I think health equity is one of the most important things I could possibly think about now in the rebuilding of New Orleans. We have to think about health equity, and of course me as the mayor, this is all under my purview. I've got all of the cross-government, local government levers that are very important for this. Of course it didn't really play out quite like that afterwards, but positioning the issue of health equity at that level was very important. On the right hand side is another Scot. He was the Prime Minister in the UK at the time when we reported, so the Commission reported the WHO Commission reported in 2008, and we were having this big global conference to speak about what we found out about, and we thought, well, the Minister for Health is going to be the person where we've been engaging with the Minister's office. Gordon Brown, and maybe it's his social, he's from a very working class background. He said, I want to open the conference. I think it's at that level of government that we should be thinking about these issues. It's not just a Ministry of Health issue, it's at that level. So getting that sort of, and then of course the government changed and it was a disaster. The other thing, of course, to think about is how you position at that intersectoral working. So, of course, everything that I'm speaking about is intersectoral working, whether it's at local government level or at all levels. And there's this movement around health in all policies, or I've said health equity in all policies, and I wish we had done it. This is in in Canberra. I wish the local government was, all of the different departments in local government had been talking to each other, because of course we wouldn't have built this pole in the middle of the pavement if we had been, if public health, equity and our urban planners had actually spoken to each other. But there is a lot of work taking place internationally. I know here in Canada and certainly in Australia, there's a real movement around intersectoral health and all policies work. The social action being absolutely vital, the bottom-up part of this. I've spent a lot of time talking really at that policy level, but of course that means nothing without social action. And this really is just a very good way of reinforcing that message. When we went to New Orleans and going round the different areas after Hurricane Katrina, there was a lot of charity had gone into New Orleans, and helpfully so, but what became very clear was community mobilization. And we saw these sorts of signs all over the city, with the issue of solidarity, social mobilisation, not wanting a charity model, wanting sustained infrastructure to help things take place. And then to finish, the data issue. So for the researchers in the room, the data being so important to be able to demonstrate these issues. If you don't have the data, the argument might be then you just don't have a problem, and if you don't have a problem, then nobody does anything about it. These are data from Scotland, and I've called it a national disgrace, just to go with the fact that we're all dying so young in Scotland. But I'm really using it to say, so one, this is HLE, this is healthy life expectancy. Not many countries in the world calculate healthy life expectancy. We tend to calculate life expectancy. Healthy life expectancy is a much better indicator of actually living a life that we have reason to value. And having data that's broken down by area levels of deprivation. We're in a good position in Scotland that we have these sorts of data that we can demonstrate the fact that we've got this national disgrace, but many countries don't have that sort of data, that fine-grained data that you can show the extent of your problem. And this isn't at the city level, but I just want to use this as a way of reinforcing that message. So just look at the picture. This is to do with age standardised death rates. It doesn't matter about the actual indicator of the number, but age standardised death rates, the countries in Africa have the highest level of age standardised death rates, and there's little pockets over here in Asia. So that's reported age standardised death rates. That's the coverage of vital registration. So having to report, vital registration is birth, deaths and marriages, so having to report children's deaths. So you can see there are incredible numbers, many, many more countries where vital registration doesn't take place. So that means that figure is completely underrepresented, because we don't have the vital registration in all of those other countries to calculate age standardised death rates. So not having the data, and that's what it is in many of these countries, they just do not have vital registration systems in place. So by not having the data, we don't have a problem, or we don't have the size of the problem. The other issue about data is actually having systems that include everybody in them. And certainly from an urban perspective, we know that slum dwellers tend not to be captured in the data systems. So again, an underrepresentation of the communities that are by far are the most affected from a health, certainly from a health perspective. And useful systems, having socially stratified data. It was an incredible challenge for us in that urban health equity network, finding health data that was broken down by things other than sex or age. So if you don't have data that's not broken down by income, by education, by caste, by ethnicity, you just don't know the health needs of those communities. And then finally, how do we ask the question? So as researchers, and this isn't specific just to urban of course, but it's a general thing from a health equity perspective, how we ask the question depends what happens to the interpretation of that data. And what has been dominant within, I think, within the public, certainly in population health, is we talk about, from a behavioural perspective, the feckless poor, the behaving badly. It's the poor people that smoke that do this, and so therefore the response is dealing with the poor people's behaviours, and we know it just doesn't work. When we ask the question, why are they poor, or are they uneducated, or why they live, you bring back to that Jason question that I showed that the Canadian Public Health Agency had posed, then it shifts you into the social factors. So I hope that sort of gives you a sense of what we've certainly been doing at the global level. It's an incredibly challenging space, and it is the necessity for that cross-sectoral and cross-disciplinary. I haven't mentioned from a disciplinary perspective, this is all interdisciplinary work that we've been drawing on here. An incredible challenging space to work in, but there is such opportunity, I think, particularly with the fact that we've got a lot of urban growth still to take place, and that there's, I think, increasingly much better relationships between urban planning and public health now, certainly in my experience. It's quite exciting. So just to finish, I do want to acknowledge Trevor. Trevor Hancock is a very good friend and colleague. Now, when we first met, he mentioned that we met in the WHO's Commission on Social Determinants of Health, and our first meeting was in Tanzania at one of the urban knowledge networks. And we were all there from all of these different countries around the world. And we were all sitting after the meeting, we were outside having a cup of tea or a beer or something, and Trevor pulls out his hankies and starts to Morris dance, which is what he's doing up there. And it was just the start of a lovely journey for us. I just want to thank Trevor very much for really organising and getting me over here to Canada. It's been a real pleasure and privilege to have been here for the week, so thank you.
So I guess I at some point I may have to both dance and sing. But before I do that, first of all, thank you very much. But we've got actually lots of time for questions, about half an hour. So if you're up to it, and I can either manage the questions or you can pick them yourself, whichever way you prefer. If you wouldn't mind repeating the question, because for the filming of this, it's easier for them, because we're not mic'd out there, to hear what the question is.
Okay.
Points, questions, thoughts, points.
Deathly silent.
Thank you for your talk. I have a question here. So Jason Coburn last month, and you now again use this notion of stress. And I'm wondering if you could talk further about stress, the way in which that term is being used broadly within this literature, and I guess within this political movement also. To my ear, the term stress seems to me, and I have no basis for saying this, but it seems to me that in a sort of Canadian political context at least, would not sell to non-believers essentially. That stress can be a useful term for the converted, but that to sell the kind of grave health problems that you're describing, and then you can support in evidence here that stress would underplay, the notion of stress would underplay what you actually have to present. So I wonder whether there's this concept, how it is received, how precisely you're using that term.
I don't need you to repeat that, that's fine. interesting. I've not been asked that before. I suppose the stress, the discussion around stress has come out of within the population health world, and then with our biomedical colleagues. So for us, within population health and social determinants, we're sort of almost taking it as a given that some of these broad societal factors are affecting health inequities. And then the question that gets posed by our more biomedical people would say, yeah, but how does that actually, they want the pathways, the biological pathways by which that is happening. And until fairly recently, probably about 10, 15 years ago, there would have been the behavioural model, so people are exposed, I'll use the food as an example, so people are exposed to these broad food environments, and there's excess availability of the deep fried Mars bar, and so they eat more of that and it makes their health bad, and that happens more in lower socio-economic groups compared to others. So there's a behavioural pathway that is up there. The biomedical people can absolutely understand, it goes into your arteries and you drop it. But then that doesn't explain everything within the health inequities pie. And then people started to, with the notion of the psychosocial control, or then it was about, or not then, there was also the pathway, the material pathway. And colleagues would argue that it's about poverty, and it's the poverty per se, not having enough material resource was just bad. And people say, that's not enough, that doesn't tell us how does it get under the skin. And that, I think, was then where people started to think about this psychosocial control. So there are these sort of three pathways, often interconnected of course. So the material resource, the psychosocial control and behavioural. And the work within psychosocial control was, a lot of it was being done by Michael Marmot and colleagues across Europe, who were starting to see the fact that there was a social gradient among people who were not materially deprived, but there was a social gradient. And they said, well, why is that the case? Why do we see these differences in health outcomes among civil servants, who are of course not poor, but there's this social gradient, and that led them to start to investigate work stress. And what became clear, and of course that we all experience in current working day life, is quite different demands on us and levels of control in decision making. That was very different across the social structure within the civil servants in the UK. And they said, okay, well we're able to see that. How is that getting under the skin for people? And what they then observed through sort of biochemical markers were changes in hormone levels. Stress-related hormone levels are different across the social structure within the civil service. And without getting into the biochemistry of it, because I don't know the biochemistry, so hormone stress levels are different, and that has been observed now across different income categories as well. So the poverty argument might come through the psychosocial pathway as well, so through the stress. And then there's been an increasing literature within the social inclusion world that looks at these compounded, is that English? Multiple stressors, potential stressors, so not having enough money, the racism, the not having control at work, or feeling that your life is out of control more generally. And they've measured the fact for those people that experience these different stressors, their cortisol, the hormone level is different. And when you experience that chronically over time, your ability, so we all have stress and we all respond to that in different ways, but it's actually quite good that we have acute stress. But when it builds up over time in a harmful way, it's very dangerous for health. It's very dangerous for mental health, but there's also a very high association with coronary heart disease as well. So that might be a long way of,
Sorry, just to extend that a little bit. So, as Sharon said, it's not about acute stress. It's not like I had a really bad hair day or a bad week or whatever. This is about lifetime stress. And in fact, Clyde Hertzman, who I mentioned earlier, developed the concept of the biological embedding of these experiences that actually start prenatally. So if your mother is stressed, then that is experienced with intrauterine while you're developing, and you're born different. And if throughout your early childhood and youth, this continued stress from all of these different factors, so it's chronic lifetime stress, so we talk about the life course experience, and it's something you never really quite get rid of, so you will have a different life experience and a health experience because of what happened to you prenatally and in those first few years, which is why there's such an interest now in the first few years of life and how important they are. And there's a pathway called the psychoneuroimmune system, which basically says that what you experience here is transmitted through your brain and the way you perceive it, and through what that does to your neurohormonal system into influencing your immune system. Now, the immune system is involved in infection, it's involved in allergy, it's involved in cancer, and so when you start to, and it's involved in inflammatory conditions, which includes some cardiovascular disease and so on. So once you start to put all that together, you begin to see, I actually have made an argument that democracy can prevent cancer. In as much as that empowerment process, as it gets internalized and transformed into biological change, if it's positive, can have those kind of things. So that's what we're talking about when we say that it's a lifelong stress. So it's not a bad hair day, it's that process that starts prenatally and carries on throughout your life.
here, and then here, and then here.
Maybe a question in two parts then. The first one's kind of etymological, the second part maybe more practical. Your title, your position, and so on, uses the term equity. But early on, in some of your early slides, like your comments and even one of the slides, seems to elide, use inequality as a synonym in a way for equity, and set up a kind of relative feature, right, between the affluent and non-affluent. But I can see reasons why maybe one would want to disambiguate the two. Because, one way of making everything equal is to tear down the building and and make it all a favela. But that wouldn't solve the problem that equity is seemingly getting at, right? Which has a kind of more justice valence. So I'm wondering, one, if you have a definition of equity that you're functioning with that kind of guides this process. And then secondly, at the end of the last talk, Trevor hopefully kind of asked like the so what question. How does this play out then for us? What's upshot? And I'm wondering if you have a kind of hey, affluent Victorians. This is maybe some of the implication of what I'm talking about in terms of your life, your lifestyle, your actions, and so on.
Your pitch as man.
Well, your question, your last question, of course, is the $1 million question that everybody asks. Not just me. Can I start with that, because it sort of relates to what I mean with equity or and it's not, here's the 3 things to do going out the door. So I hope, what I'd hope to do with what I spoke about within the talk was to point to the complexity. So addressing urban health inequities requires a complex systems approach. And what that can often provoke is people saying, oh, well, I haven't got a clue where to start in all of that. What do I walk out the door? What can I do now with that? And my response to that is, it's not for you, or for one to try and deal with all of that. There's no one person who can deal with all of that. The point is to say it's a complex system. There are many entry points that we can go in through to address urban health inequities, and we need to use that broad, complex framework, but that we can, either the different disciplines or the different sectors can see themselves, I hope, in that complexity. Because that's often, certainly the pushback that I would get quite often is saying, oh, there's too much, we can't do anything about it, so we're going to walk away and we're going to deal with behaviour, or we're going to deal with access to services. And I say, that's fantastic. If you get access to services right for all urbanites, then you're doing what I've just been speaking about. As long as there is some, and I would say some broad policy framework, so for you to walk out the door, to go to local government and say, this is the sort of framework that we want you to work in. It's got to be about principles of equity, it's got to be about principles of sustainability, it's got to be about whatever else is in there. So it's a bit of a dual role, if you like. So that's me, of course, avoiding your question of what to do. Your first one about what do I mean by equity, and I do often sort of mix the equity and inequity together. I didn't realise I'd mix the inequality together, but that was good to identify that. Because so in essence, the inequality is the fact that there are differences. There's differences in the health outcomes, there's differences in what people are exposed to. But the fact that there are these differences which are harmful means they are unfair, so it is about the justice idea. They're unfair and they can be prevented, so it doesn't, there's no reason for people to experience those differences in health outcomes. So I'm coming at it from being interested in how this affects health, which is some colleagues would say, are you not interested in it because of the social issues? And I said, of course I'm interested in the social issues, but it's because they affect health. I don't have a mandate to think about the whole of the world order, and I don't know everything about the world order. It's how these things might affect the differences in health outcomes. So therefore, operating around the title of health equity, which I argued very strongly for at the university in Australia, was to bring the principles of social justice, of fairness. So we can't use the term social justice or equity really in policy discussions in Australia much at the moment. But to bring those principles into health policy discussions. So the fact it's about addressing the differences in health outcomes through fair and just means. That's the broad church. And you can get to that in very different ways. You could tear down the tower block, but we know that's not the way to do it. Oh, sorry, so yes.
I was intrigued by the slide that you had a brief explanation of a study talking about CO2 emissions and its impact on heart disease. Can you say some more about that? Because I've never seen that correlation when one is talking about like greenhouse gases and so forth.
Yes, I'm conscious I haven't been repeating. Is that you're catching it? Okay. So the idea of thinking about greenhouse gas emissions and the reduction of greenhouse gas emissions, and then what the health co-benefits is the language that's been used. There was a series in the Lancet journal that we published, which was, so we asked the question, this was colleagues from all around the world, we asked the question, if it's about, for climate mitigation purposes, so it's coming out of the climate mitigation agenda, climate change mitigation agenda, if we want to get to the greenhouse gas emission targets, so using all of that discourse. If we want to get to those targets, the sectoral targets, so there was one to do with transport, there was one to do with the food sector, there was one to do with domestic energy, and something else. And where the targets had been set, so that's why I used the UK as a benchmark, because there had been a number of targets set, emissions targets. And then just said, okay, well if you do that, there are potential health, but positive health consequences for that. So it was a modelling exercise, it was an absolute nightmare. I've got no idea of the actual quantitative modelling technical aspects. We had some great colleagues at the London School of Hygiene and Tropical Medicine that did the actual numbers work for us. But so we took the emissions, worked out how the level of emissions to get to, and worked out by changing, and I don't know the travel one as well, I was actually doing the food one, but working out how many people you would have to move into active transport to walking and cycling, and that's what I meant by active transport. So getting people walking, getting people cycling, getting people onto public transit, mass transit, and then there's a little bit and what that would do in terms of emission reduction. And then there was a bit left over, so there was I can't remember the proportion of shift that needed to happen into that sort of travel arrangements. There was a bit left over that allowed for sensibly having some sort of public, private vehicle use, but of low emission type. And then we modelled what that would mean, because if you had all of these people now being physically active, that argument I was showing with if the child walked around the neighbourhood, then the energy expenditure that would be associated with that and what that would mean for ischemic heart disease. Do you want to have that?
Well, just to, so I think part of what you're saying is you haven't heard the link between CO2 and heart disease. It's not actually the CO2.
No.
It's that when those vehicles are not emitting, they're also not emitting particulate matter, nitrous oxides, and so on. And so air pollution goes down. And it's the air pollution, the non-carbon dioxide, or the other forms of air pollution associated with vehicles, that are the causes of respiratory and cardiovascular disease, quite high causes. I mean, in southern Ontario, it's estimated thousands of deaths annually, tens of thousands, I think now. So it's the decrease of the pollutants that cause cardiovascular respiratory together with the increase in physical activity and therefore cardiovascular fitness. So it's that double benefit. So it's not directly the CO2 itself.
I'd just like to thank you. First of all, it's been great. And I guess I'm coming from a nursing background, and my question is around engaging healthcare providers, because obviously when we're talking about health outcomes, that's something that nurses and doctors and whatnot study pretty extensively, and I think we do come from a very biomedical model. Of course we talk about the social determinants of health and all of that, but we're very focused on the healthcare systems, and I'm just wondering, in your experience, have you seen good examples of when healthcare providers have been engaged? Like, I know the World Health Report does encourage healthcare providers to advocate and be leaders in health promotion, and just wondering if you can speak to that.
Yeah. I should probably have started the talk by saying everything that I'm going to speak about is in addition to what happens in healthcare, because the healthcare system is both a determinant of health inequities and is also a source of incredible opportunity and solution to address and deal with health inequities. So it's not an either or. And there are some very, very good examples of healthcare systems. Canada would, of course, be up there in the world. You still have you still have health inequities within Canada. But compared to some of the other countries in the world, the way that you deal with that within your healthcare system is often to be applauded. Every country can do it better. So whilst, and I do think the healthcare system plays a dual role, if not more, but it's a dual role in that you've got to think within the healthcare system how you make it much more equitable. And that goes some of the way to addressing health inequities. But that's about dealing with the people that are coming into the healthcare system. So they're already sick. We're not talking about primary healthcare, but they're coming into the healthcare system being sick. But you want to make sure that there's equity within that. So getting the healthcare system to function equitably is a very important thing that can be done. And then the healthcare system being open to and proactively engaging with non-health sectors, and that's where it really takes you into the primary healthcare level of the healthcare system, engaging out with intersectoral action. And there's, I think, a nice term about the sisterhood between primary healthcare and social determinants of health. We were just at the session this morning, lunchtime, you're talking about issues of power, and I would say, and the literature tells us, that one of the things for us within the healthcare system is letting go of power and recognising that the healthcare system will not solve all of the problems alone. It's one of the things I think that the health and all policies work is really showing us, and showing us how to do that, of real engagement with the non-health sectors. But it means for us within health standing back. So getting equity into the healthcare system, and how you equity of access to affordable medicines, equity of just all of that within the system. There's a lot that needs to be done, and then connecting out to with intersectoral action. And that might not be something that, as a nurse, you wouldn't necessarily on your day-to-day job be doing, but you can be connecting, proactively connecting colleagues out into the system, or advocating for. The nursing lobby is so powerful. Well, I know internationally it's so powerful. You have a very strong voice that's heard. If you're saying we need much more of these sorts of things, and the role of the healthcare system in doing that, then people listen. When the medical professions say these sorts of things, people are listening to it. It was one of the things. Michael Marmot was the president of the British Medical Association, and he took on that role when he was asked to be president of the British Medical Association. So the most powerful group, if you like, in the UK, or one of the most powerful groups in the UK, in health. And he said, what my agenda is going to be. It's going to be about social determinants, it's going to be about health equity. Do you really want to do this? And he said, yeah, it's time for us to have a bit of a shake-up. And he said it was a very difficult thing to do. He was to get the very mainstream medical association to do this, but the voice, the collective power of the BMA was not to be undersold, and I would imagine that's similar here in Canada and the other allied health professions as well.
And of course, as a nurse, if you go into public health, you can do this.
Of course.
That's the plan.
So lots of hands. So, are you?
Well, a couple of quick questions. As I see
So we start. Okay, yes, the man behind you.
Okay, so just picking up on your kind of somewhat evasive answer to the gentleman over there about what we should do next. Let me just pose it this way, let's go back to Glasgow and give you the new position of, Mayor of Glasgow. So where are you going to start in a city like Glasgow? Or you could be Mayor of Victoria if you like. You could be Mayor of Melbourne or Sydney or wherever in Australia. But where, at the local government level, where do you start? And if you want a second question on, if that's not complicated enough, how about being Gordon Brown or, well, not Gordon Brown, but whatever the guy is these days. Cameron, where should we start? Where should we be kind of Start.
Well, I'm not going to be the mayor of Glasgow because Glasgow, as we were at another talk on Tuesday, and nothing has changed in Glasgow for hundreds of years in terms of the inequities, and they've invested an awful lot of money and nothing's happened. But it's called the Glasgow paradox for a reason. Things have changed, we think, elsewhere. So I don't know what's happening in Glasgow, so I don't want to be mayor there. I think not only is it a hard question, I think it's, if I'm allowed to say, the wrong question. Because picking one, and I know that's, as a mayor, that's what I'm supposed to do. I'm supposed to have the 3 top things that I'm going to go out and I'm going to change the world with these 3 top things. And you can't do it. That's what's failed. Historically, it's failed. The evidence shows us that it's failed. But what I would say is you've got all of the, as the mayor, you have all of these government departments. You've got cross-sectoral opportunity immediately. You've got the possibility of putting into the key performance indicators for every single government department that they've got to address issues of equity and they've got to address issues to do with health, with well-being. Maybe not use the term health, but well-being. So key performance indicators for everybody. It worked in London until the mayor changed into the one that we've got. They used to have to report on issues of health equity got introduced just towards the end, and they didn't have environmental sustainability. So it means that every government department has to think about what they do. So a question to every government department would be, your policies affect social and health equity. How does yours do that? And then you work out your budgets associated with it, you work out how you deal with it. But I'm not going to say that it's about early child development, or I'm not going to say that it's just about parks and this, and I'm not going to say it's about this. We know that it's the complexity. So that's avoiding your question again.
It's actually not, it's really answering. Yeah.
Just one final question.
Yeah, and this is similar to a question that was asked earlier, but I don't have this all that well articulated, but this idea of like equity and income being tied to equity. Income being tied to equity, and income being, low income being a generalized indicator of poor health outcomes and presumably behaviors. But like when you show the slide of, for instance, the hamburger index, like in those developing countries, it's the upper middle classes that are the ones kind of getting introduced to these unhealthy habits around food in particular, being able to afford the KFC and the Western chains that go in with sort of these new unhealthy foods. And it might be people with slightly lower incomes that are still eating a more traditional, healthier diet. Mm-hmm. So it's one example of just wondering where the bar is that you're trying to reach, and how do you make sure you're not just lifting people to a point where they can then branch off into a whole other realm of unhealthy behaviors, I guess?
Yeah, it's I think a very important question for a number of reasons. Partly used as a driver, if on your logic there of, if it's about increasing income per se, and I'll come back to the income and equity in a minute, but the income per se, increasing income per se will shift more and more people into a consumptogenic environment. We've seen, which is in essence what you've just said. So you shift people to eating more and more hamburgers, more and more private vehicles, more and more. So it's that consumptogenic environment. From an environmental perspective, and Trevor will jump up here and tell you that it's a disaster if we move that way. So economic income per se is a problem. In essence, so what the burger thing was really trying to illustrate is the inequity. Now it's across cities, so it doesn't necessarily work directly, but the inequity in income. So the Gini coefficient illustration of income inequities, that's harmful in and of itself for health. That inequity in income is harmful in and of itself. Now, I'm not saying that we want to get everybody up to that level. That's a big discussion that we need. We'll do that in the pub. But with that discussion, the relative inequality in income levels in and of itself, regardless of what it does in terms of what you can buy, what you can't buy, that relative inequality, the relative difference in income in and of itself creates problems for people, and we think it's through this stress pathway. And that's a problem. So that's what I said about the more equal societies, whether it's more equal up here or more equal down, the more equal societies are better for social and health outcomes. That's the work of Richard Wilkinson and Kate Pickett that's talking about that relative inequity. One of the things that's been posed in terms of the consumptogenic environment is we've got to stop economic growth going the way that it's going. And who wants to have that conversation apart from Trevor, who really wants to take that head on? That's the new world order that we're talking about. That's why I said to you, I'm concerned about what this means for health as a protection for me. That's the big question. But your question is dead on. But the take-home message from, particularly for that, for health, is it's the inequity which is just harmful, full stop. It's just harmful for health.
Well, I'm sure we could go on, and as Sharon just hinted, we doubtless will in the pub, which is a good Glaswegian tradition. So it's another whole story behind that. Sharon, thank you very much. It's a very fitting way to end this series of 3 talks and to leave us all with a bunch of good questions, for which there are no simple answers, and that's one of the big problems in our society. We come to look for what's the quick fix? Well, there is no quick fix to this. It's a long slog, a hard slog, but what's the alternative? So it's really the only game to be in, and so thank you for that. And thank you for being here. Jordan Stanger-Ross, who has been managing this on behalf of the Urban Studies Committee, has asked me to remind you that there will be an as yet unknown set of city talks next September, funding permitting, and it usually is. So we hope to see you then, and thank you for coming, and thank you for coming.
Thank you.